Okay, good afternoon once again. It could be a rather odd topic for a pediatric cardiology audience. When Prashant asked, we have to just told me to find out a topic, something out of the box. I thought this would be a reasonable topic and to share our experience in pregnancy with pulmonary hypertension. And I'm quite sure that at least majority of you would have faced at least once in your in the dilemma regarding taking care of pregnant patients with pulmonary hypertension. So let us just have a short visit what happens during the pregnancy and why these patients fare badly when they get pregnant. We know that the plasma volume expansion happens by 50%, which peaks at around 32 weeks. The cardiac output increases by 35%, up to 9 liters near the term. And there is IVC compression by the gravid uterus, which alters the preload, which all contributes to a labile preload during the pregnancy. And the low vascular resistances, because your estrogen and the progesterone hormones bring down your vascular resistances so low to accommodate the cardiac output. And at delivery, you have the uterine contraction, which pumps additional close to 5 ml of blood back into the circulation. The IVC compression is gone because the uterus has shrunk now, so the more volume now reaches the heart, and there is a reabsorption of the extravascular fluid which is accumulated during the pregnancy, and so you feel an increased preload. And you can have blood loss, which is at times cannot be negligible, especially in a compromised patient who is having pulmonary hypertension. Up to 500 ml by vaginal delivery, and CS can up to, you can lose up to 30% of your blood volume. So that again alters your preload. So you have a very different situation when a pregnant patient delivers after a complete course of pregnancy. Your SVR and PVR goes up again, which was low during pregnancy. And again, the stress, anxiety, the pain associated with pregnancy, again increases the sympathetic mechanisms. All of this contributes to the increasing afterload. So what is the problem with RV? As we have discussed early in the morning, very good talk by Radharshan sir. It's very thin-walled compared to an LV. It's only 1/6 the mass of the LV muscle mass. A complex geometry with longitudinal and transverse muscle fibers, and it is designed to accommodate a low-pressure system, to act as a chamber conduit between your right atrium and the pulmonary artery, which is always a low resistance circulation. So when you have a pulmonary hypertension, your PA pressures are elevated. So obviously your afterload is more. You long-standing PH tend to have RV hypertrophy, ischemia, muscle fibrosis. You can have RV systolic, and in addition, diastolic dysfunction is very well described in patients with pulmonary hypertension. On top of that, you have a labile preload, as we discussed, hypoxia, hypovolemia, acidosis, any sort of insult during any of these delivery procedures can add on to the hemodynamic derangement. All these can elevate and stress the RV, which can ultimately result in RV failure. So the complex mechanisms which are operating in a normal woman would pass off as the phase of pregnancy comes down, but in a pulmonary hypertension patient where your vascular remodeling doesn't happen as normal, your PVR is already elevated, your pulmonary vascular bed is not adaptive for the changes, all these malfunctions can set in. So mainly, if you see in a pulmonary arterial hypertension perspective, in a structurally normal heart, like a patient coming for delivery who is having an idiopathic pulmonary hypertension, or connective tissue disease, or a patient who is having residual pulmonary hypertension after you closed a shunt, your cardiac output is RV dependent. You do have no other way to maintain the cardiac output. RV has to function. But compared with that, the Eisenmenger syndrome, the cardiac output can be maintained by increasing the right left shunt with a at the cost of obviously a low saturation. Your systemic saturation goes down, but your cardiac output maintains. That's why if you see the literature, the patients with Eisenmenger syndrome tend to have a better outcome when compared to those with structural normal heart. So let's see one of the case scenarios we faced in our institution. She was a 27-year-old female housewife, first visit in 2014, came with exertional dyspnea of 2 years duration. She already had a 2-year-old child. There's no family history of pulmonary hypertension. Clinically, she had severe PAH, WHO function class 2, no evidence of right heart failure, normal saturations. This was her ECG, which was not rather very much striking. X-ray also was not much worse. It was not conclusive of anything. We did the echo, which was showed a severe pulmonary hypertension with an RVSP of 62, normal RV function, otherwise structural normal heart. Lung perfusion scan was negative. There was no evidence of thromboembolism. Other secondary causes workup was negative, and the BMPR2 mutation was negative for her. And we planned for a cardiac cath. So just to complete the list, this is the routine list which we do for all patients who present with IPH as an initial workup plan. So routinely all the patients go through this panel of workup when they don't have a structural heart disease. When you're suspecting IPH, the right saddle panel we do for all patients as a routine part of our workup. So during the cath, we had a
clarification. This was during which trimester of pregnancy or before pregnancy?
No, this is before pregnancy.
Before pregnancy.
She's not yet got pregnant. Yeah. So baseline data, she had a mean PA pressure of 50, and the shunt resistance was around, PVR was around 14.6, SVR 23, and PVR SVR ratio of 0.6. With nitric, did not have much fall, came down to 42. The PVR came down marginally to 11, so she was labeled as acute vasodilator test negative, and was started on tadalafil 40 milligram and ambassador 5 milligram, the best combination therapy possible, and also on warfarin to maintain an INR between 1.5 to 2.5. 6 months follow-up, symptomatically she is better, WHO function class 1, echo, the RVSP improved, TAPC better, normal RV function, 6-minute walk test was 480 meters, no dyspnea or fatigue. After 3 years on dual therapy, she remains status quo, function class 1, doing well. Now comes wishing for a second child. So I think it's election time now, so the nation wants to know, how many of you will not recommend pregnancy? Anybody want to raise both hands to be severely contraindicating pregnancy? Anybody would go for pregnancy? Okay. So I tried, obviously, convincing the family that not a good idea. You can have complications, and you might even die. So what she told was, I don't care. I want a second child. I can die for my family. Okay, great. So we recapped while she was on dual therapy just to document the hemodynamics. So the baseline pressures were 30 now, mean PA pressures. Previously it was 50. PVR has come down to 6 from 14.6, which was her baseline before the start of treatment. It just gave nitric for completion's sake, which didn't bring any much of a change, but he had a reasonably good hemodynamics. So we stopped ambrisentan and warfarin, waited her for 6 months and tried telling her not to get pregnant because anyway it's not in our control. She RVSP came up to 45, but the function was preserved. She didn't deteriorate in her function class. Allowed to go ahead with pregnancy, and we continued tadalafil 40 milligram once a day. She delivered, the pregnancy period was uneventful, delivered a near-term 37 weeks by CS because the previous delivery was CS and we didn't want to complicate things. A healthy male baby, 2.1 kg. We always have a radial arterial line electively and a right IJV catheter when the patient goes to the labor room, irrespective of the clinical status. We prefer epidural anesthesia over a GA, which is always backed up by noradrenaline infusion because the commonest complication when you have giving an epidural is systemic hypertension. So we avoid GA now. So we have most of the time give epidural, slow epidural, controlled one. The patient will be always on oxygen inhalation. We keep a backup of nitric oxide and IV as standby. She had 4 days of ICU stay post-delivery. So immediately after the delivery from the labor room, the patient will be shifted to cardiac ICU for monitoring. And 6 days in the ward. We routinely give heparin for 5 days to 7 days to prevent any thromboembolic events. Actually, there is no evidence suggesting that, which prevents like any thromboembolic episodes. But as we know, the pregnancy is a procoagulant state. And especially with Eisenmenger syndrome, she's not an Eisenmenger, who can have polycythemia and high evidence of thromboembolism. We routinely give thromboembolic backup because they will be lying down in the bed without moving. And we also advocate leg stockings and lymph therapy to prevent any DVT. and restarted her back on tadalafil 40 milligram and ambrisentan 5 milligram once a day. She was on tadalafil, we restarted ambrisentan. And 1 month follow-up post-delivery, she has remained well, function class 1, RVSP 45 with normal RV function. So these were the RVSP trends during the pregnancy. We asked them to come for visits at regular intervals, preferably 6 weeks, 14 weeks, 24 weeks, 34 weeks, and at the time of delivery. So the RVSP, when we stopped, you can see it has climbed up to 60 at 24 weeks, remained almost the same till delivery, and came down to 45 1 month post-delivery. We also follow with BNP, which is very useful marker because we know when the adult patients get pregnant, your echo windows can be really poor. And it's very difficult to assess the cardiac function. So one surrogate we use is the BNP trends, and we do that throughout the pregnancy when they come for each visit. And you can see that it jumped to 112 from a baseline of 43 immediately post-delivery, and by day 7, the BNP trend normalized. Again, signifying the fact that your RV takes a big hit in the immediate post-delivery period and the most critical period where the mortality and the complications can happen. WHO functional class trends we have already mentioned. She went up to functional class 2 during pregnancy, but then came down back to 1. And the TAPC was rather preserved throughout the pregnancy. One more case, interesting one. We had a 22-year-old female from a far-off place in Kerala. Unfortunately, she was diagnosed to have pulmonary hypertension when she was 24 weeks pregnant, her first child. So started with shortness of breath and palpitations. She was in function class 2, no frank right heart failure when she came to us, saturating 96%, echo showed severe PH, RVSP was 75, suprasystemic septal position, structurally normal heart otherwise, TAPC was normal, fractional area change of 29%, and BNP was elevated. It was 907 when we have the lab cutoff value of close to 225. Actually, our legal limit for termination is 20 weeks, so we couldn't terminate the patient. Counseling the parents and the husband, we had to go ahead with the pregnancy, but we had no other choice. The fetus was well preserved with adequate weight. So this was her echo when she came for first evaluation. You can see in the frozen frame, the septum is really flat, indicating a near systemic PA pressures. We started Halon sildenafil because that's the safest drug you can give on pregnancy. Endothelium receptor antagonists are contraindicated. We restricted the physical activity and asked her to stay close to the hospital because she was a little far away staying before. Like it will take her to reach at least 4 to 6 hours to reach a hospital in case of an emergency. So we asked her to shift the home close to the hospital and came for a close follow-up. We serially followed up her up to 36 weeks without much drawbacks. And at 36 weeks, we did the fetal scan to make sure that the fetal growth was adequate. And she remained in this almost in the same function class without no significant events. Her NT-proBNP almost remained the same at around 900 and was admitted for an elective delivery. We planned for an elective induction, but it failed, and we straightaway progressed to elective cesarean, keeping on oxygen saturation. During epidural anesthesia, she had a little bit of hypertension, which was treated with noradrenaline infusion. Delivered a 2.9 kg healthy female child. Sterilization done, obviously, and was shifted back to cardiac ICU. So she was on stiff supports, adrenaline, noradrenaline 0.08, and on oxygen. Echo showed worsening of RV function. The TAPC came down. And 1 hour later, she had a massive vaginal bleed with hypotension. She had an ectonic uterus. That was the cause for the immediate postpartum hemorrhage. We managed with fluid volumes. Noradrenaline had to be hiked up. Pitocin infusion was started. Blood transfusion was given. And injection heparin we started only once the bleeding stopped. Added on ambrisentan and other measures to prevent DVT. DVT was also instituted. And finally, 1 week in ICU stay, I could literally see her function class worsening from 2 to 4. The moment she tries to get up from the bed or tries to sit from the bed to the chair, she would become really breathless, and you can see the arterial BP coming down very drastically. Slowly weaned off noradrenaline by day 4. Again gave heparin for 7 days. She was still auto-dependent, restricted to the bed, and finally shifted to the ward. 11 days in ward, slowly weaned off O2, and by postpartum day 14, she was almost ready for discharge with a saturation of 95% of O2. And again, we cautioned her regarding restricted physical activity and added on ambrisentan also, because she was not started before that because she was pregnant. So this was her NT-proBNP trends during the pregnancy. As you can see that delivery time it was close to 900, and by the day 10 it has reached up to 6,000. Again indicating the strain the RV undergoes in the immediate postpartum period. Again emphasizing the fact that it is the delivery and the immediate postpartum period which is the most vulnerable, and the literature, after literature proves that that is the maximum time when you have a maternal mortality when you try to deliver a pregnant patient. Her function class, as I told, it deteriorated during delivery, came down to function class 4, and we have now 10 months follow-up with her, and she's doing reasonably well with function class 2. 10 months post-delivery visit was done 2 months ago. The fractional area change also plummeted during delivery and slowly recovered post 10 months up to 33. And these are the RVSP trends. Again, immediately after delivery, it fell to 13, and then slowly picked to a value of 21 after 10 months of delivery. So first post-delivery visit, that was 45 days after delivery, she remained in function class 2. Again, echo showed severe pH, TAPSE was good, BNP had come down to 547, but still not normalized even after 45 days. We continued the same medications, and 10 months post-delivery on dual therapy, her BNP had almost normalized by 91 value, and she is bad news, she is a non-BMPR2 positive. It's a well-described mutation, not a novel one, but she is positive. And we planned an LT cath study because we couldn't do the cath when she was pregnant. So we planned for an LT cath study, and surprisingly, the pressures are much better now than we saw when she was pregnant. The RV is robust. You can see a full round septum now, which was very much different from the flattened septum which we saw when we screened her initially during pregnancy. So the baseline data, her mean PA pressure was 35 on dual therapy. PVR was close to 3.7. With nitric oxide, didn't make much difference. It almost remained the same. So if you see the literature, in the Esther year, this is one of the best quoted article in the last century regarding mortality from pulmonary hypertension and pregnancy. The mortality was highest in associated pulmonary hypertension, with Eisenmenger syndrome having 36% and IPH having 30% mortality in the previous era. And the risk factors were late diagnosis and late hospital admission. And the only drugs available during that era to treat were calcium channel blockers, digoxin, and anticoagulants. And the fetal or the maternal mortality, the fetal outcomes were also equally bad, with only up to 12% of babies dying during pregnancy. So in 2012, Jays et al. Published another data, which is a prospective study, 26 pregnancies in a 3-year time period, where 62% were successful. They had 4 deaths, actually 3 mortality and 1 urgent heart-lung transplant, which would amount to a death in our situation. So 4 deaths. And he found that those who had the worst hemodynamics, that 16 deaths in those who had worse hemodynamics compared to 4 deaths who had a reasonably good data at the baseline. And this is one of the latest studies which is published recently in Journal of American Heart Association, a huge sample size looking into the outcomes of pregnancy and pulmonary hypertension. The studied period was from 2003 to 2012. They looked at the major adverse cardiac events like death, cardiac arrest, any shock, myocardial infarction, respiratory failure, arrhythmia, or any embolic event. And they included all sorts of pulmonary hypertension, not only the pulmonary arterial. They also included the pulmonary venous hypertension and all the categories. The maternal mortality was around 7.8%. in those who had pulmonary hypertension compared to almost nil in the normal population. And when they looked at the incident rates of the complications, the pulmonary hypertension group had an incidence of 24.75%, while those without heart disease had an incidence of 0.37. And they again subclassified and so the incidence, and those with IPH had an incidence rate of 20.2, and those had associated congenital heart disease had 15.3%. And when you see those associated with pulmonary valvular heart disease and PAH, it rose to 27.3%. If you had a combination of valvular heart disease and congenital heart disease, it rose to 33. Cardiomyopathy and PAH, it was even bad, 59. And finally, if you have a combination of cardiomyopathy and valvular heart disease with PAH, your rate is up to 62%. So if you see the various etiologies, the best outcome still holds good for pulmonary hypertension associated with congenital heart disease and IPH population. So if you have a venous hypertension or a valvular heart disease or a cardiomyopathy, the risk factors and the outcomes are going to be bad. So this was our data which is compiled over the last close to 10 years. We had 29 pregnancies from 19 patients. So obviously some patients have delivered multiple times. 13 were Eisenmenger syndrome, 2 were cases of idiopathic pulmonary hypertension, 3 had residual pulmonary hypertension, like after closure of a shunt, they continued to have elevated pulmonary arterial pressures, and 1 patient was an SLE patient. We had 20 live births, 3 MTPs. I could scare only 3 of them, so they're willing for MTP. The rest all wanted pregnancy. And 3 abortions, 2 stillbirth, and 1 neonatal death because the patient delivered very prematurely at 24 weeks. We couldn't salvage the baby. Vaginal delivery was possible in 5 patients, emergency CS for various indications in 10, and elective CS in 5. The mean hospital stay was close to 30 days. The moment you admit the patient until the patient gets discharged, up to 30 days. And the mean post-delivery stay was close to 2 weeks, and your mean ICU stay was 1 week on an average. We want to be really cautious that when we send them out from the ICU or shift out from the hospital, we are reasonably sure that they can go home. And we have 1 mortality, which was a late referral, which was not under our follow-up. It was a VSD Eisenmenger, and the mother went into frank right heart failure and was delivered to us on a ventilator when she was 34 weeks pregnant. We tried to save her, did an emergency CS, but the baby had already died, and within 6 hours, mother also succumbed to death. So that is 1 mortality we had, which was not our follow-up patients, but was rather transported in an emergency fashion from an outside hospital. So we have a team, Purple, in our institute. We have, we take care of all the patients with pulmonary hypertension, and when they get pregnant, we consult with the obstetric team. We have an obstetric anesthesia team which are taking care of the specific aspects of the pregnancy. We have a cardiac anesthesia who comes up as a backup when the patient is admitted for labor or when they go for CS. Obviously, neonatology has to be there because most of them, especially the Eisenmenger patients, are either preterm, low birth weight, or IGR. So all of them need exceptional neonatology care also. And of course, sometimes we go out of the loop to get help from our pulmonology and rheumatology colleagues whenever the situation demands. So, safe pregnancy in pulmonary arterial hypertension subset. I am not advocating that every patient should get pregnant. Possibly, it was feasible because we somehow naturally selected the best candidates. All our patients belong to the pulmonary arterial hypertension group, rather than a venous hypertension group having a cardiomyopathy or valvular heart disease. And we had a reasonable meticulous follow-up of the patients before they could get pregnant and make sure that they might tolerate the pregnancy, but however, the risk was told to all the parents and the corresponding couples. So case selection is of paramount importance. Strict monitoring throughout the pregnancy, during delivery, and after delivery. And it's a teamwork. Alone, you can't achieve anything. You need the gynec team, the anesthesia team, and also the neonatology team to be around. And very important, the peri and the postpartum care, because as I told, that is the period when you can have the maximum events. So possibly this is my last slide. Some interviewer was asking, what do you think most about during the day? The question was to the late, great Stephen Hawking. So he told, women, because they are complete mystery. So at time, I feel my wife, why? My wife is behaving oddly. So when I ask them, why do you behave like this? Because I am woman. Okay. So then I think of Stephen Hawking. At least he's more intelligent than me. I accept that. I think the married men in the group would definitely agree. It's not offering the fairer sex. You're always great. And I think I'm managing the pregnancy and pulmonary hypertension. I am becoming a feminist. And growing a little bit old now. And I would say 30% of my gray hair on my scalp is because of pH and pregnancy. Thank you. Any questions?
Thank you, Shine. One question from me. What do you do? So you have restarted ambrisentan. So
Yeah.
what about breastfeeding?
It's not contraindicated. It's only a relative contraindication. I have found no harm in feeding after starting ambrisentan.
Breastfeed all the patients?
All the patients. And even one patient, actually, she was 16-week pregnant without knowing, and she was on ambrisentan. Only one case. The fetus didn't have any major malformation. We confirmed that by ultrasound scan and all the other evaluation, and then only proceeded with pregnancy. But after pregnancy, in my experience, I have not seen any any problem for the child by giving ambrisentan to mother, because all of them will need it. In the immediate postpartum period, most of them will need it, especially IPH patients. And I have not found any major adverse events for the neonates. It's only a relative contraindication. It's not. Yeah.
The infant liver is probably not mature enough to handle that.
Yeah, that concern.
Yeah, that's a concern about that. But
yeah, it's not like there are some data from the animal studies, but not yet proven in vitro also, not conclusively proven.
Yeah, thank you for this exhaustive talk and sharing your experience. I just want to make a comment that in your acute care,
Yeah.
I mean, I don't know whether you gave Milrinone, because Milrinone is a very good drug for acutely tiding over the pH part. What would you say?
I have tried in one patient, sir, but it didn't work. I don't know why. We have always found that a vasopressor. Okay. Okay. Yeah. So the anesthetists always prefer NORAD, because when they give the epidural, to avoid the systemic hypertension. So the patient comes with NORAD most of the time to the ICU, and I also find that rather convenient in titrating and maintaining the BP, rather than that time shifting to a different Milrinone. Okay, okay. That I have not have had much experience.
Excellent case. Your second patient was quite sick and symptomatic. Did you at any point consider doing a balloon septostomy to make things easier for the mother? And I know the baby won't like little drop in saturation, but did you consider balloon septostomy?
But no. No, yeah. No, sir. It will be too much invasive. Yeah.
Circumstances, but this was somehow too. I didn't have the courage.
Safer for the mother. Probably it's not safe. Safer for the mother. Mother was on the edge. You can see the PVR. If
See them.
PVR is less than, say, if it's more than 25, you don't do it. If it's less than 10, you can. Then the saturation will not drop that much.
In any case, it's like a very, very delicate circumstance, and I absolutely didn't have the courage to do it.
If the forward output is the issue, then you go for it. It's not that much of issue, because she handled it eventually.
Yeah. Because
No,
she
but
didn't
then
have any problem during pregnancy. We had been monitoring very closely.
Fortunately, and 5% mortality must be one of the best in the literature.
And And I think, sir, if we had any concern with worsening of the pregnancy, we would have terminated the baby at any cost to save the mother. I would not have attempted for a septostome.
Terminating beyond 25 weeks will be as risky as.
Definitely, sir. But in case if you had to, yeah. Thank you.
Now I would, excellent talk and very good.